Trevor is a physical therapist and has a PhD in rehabilitation sciences. I think, Trevor, you did all of your training in Florida, right? And has been up at Duke for 3-4 or so years on faculty there in orthopedic surgery, also with appointments in the Duke Clinical Research Institute, and I think Margolis health policy as well. Trevor does a lot of work in the area of osteoarthritis and pain and health services broadly. I've had the pleasure of working with Trevor on a very large VA pragmatic trial in the space of back pain. He does great work, and so I'm glad that we could get him and come to talk with us today. And he's going to talk about mental health phenotyping in OA. And so, Trevor, take it away.
Yeah, thank you very much. I'm really happy to be here today and to share some of the work that I'm doing in this area. Thanks so much for the invitation. I'll start off just by giving a little bit of background on why this topic is so important, particularly in osteoarthritis. And then I want to talk about some of the research that we're doing, and then how we've implemented this concept of phenotyping within a comprehensive osteoarthritis program that we have here at Duke called the Duke Joint Health Program. So just getting started here, I've got a couple of disclosures, none of which represent a conflict of interest, but want to acknowledge these as I get started. What I'd like to begin is talking a little bit about the concept of mental health. I think we all have our ideas of what mental health is, and because I'm going to be talking a lot about it this morning, I want to make sure that we have some operational definition of what exactly I'm talking about. So the way that I'd like to do this is just a quick word association exercise. This is something you can play along at home and think about what are the concepts or the diagnoses, the characteristics, the factors that you commonly think of when you hear the term mental health. Some that come to mind for me, and I think for many people as well, are some of the characteristics or the diagnoses, the different things that contribute to mental health, like depression and anxiety, mood disorders. And in fact, when we think about how we evaluate mental health in most healthcare settings, it's screening for depression and anxiety. And that's really because these characteristics, these conditions, have a major impact on outcomes and prognoses for people with pain specifically. There are also characteristics like grief and stress and anger. Because we're talking about a musculoskeletal condition, and where there's oftentimes pain associated with that, there are pain-associated mental health psychological or characteristics associated with that. So things like fear avoidance beliefs, whether that's fear of movement, fear of activity, fear of getting back to work-related activities, fear of re-injury if somebody's been injured, catastrophizing, which is rumination or magnification about pain. All of these contribute to somebody's mental health when they're experiencing a musculoskeletal pain. There are also different characteristics that confer protection. So self-compassion, optimism, different measures of resilience like grit. These things can actually help to protect people against some of the negative effects of like depression, anxiety, for instance, in contributing to their overall level of mental health, and a variety of other characteristics that are related to mental health. And the reason that I bring this up is because as we're talking about this concept today, I want you to recognize that it's fairly broad. It goes well beyond just depression and anxiety, which we most commonly hear about, to include all of these different things. And I like this definition from the World Health Organization. It says that mental health is a state of well-being that enables people to cope with stress, realize their abilities, learn well and work well, and contribute to their community. We know that it's not just the absence of mental health disorders, and that it is something that is highly personal for many people. I'm not going to belabor the point on these next couple of slides too much, but I do want to make sure that create this link or remind you of the link between mental health and psychological characteristics and pain and function for people with osteoarthritis. We have a lot of literature out there that shows that there is a relationship. A lot of that work is done in pain, anxiety and depression. But whether we look at people with just osteoarthritis generally, or we consider those that go on to have total joint replacement, we've seen things like pain catastrophizing as an important prognostic factor for how somebody is going to do after their joint replacement. We've also seen some trials that have looked at interventions related to pain coping and seen some modest effects in improving levels of pain coping, and various mental health characteristics for people with osteoarthritis or after joint replacement. So we know that there is a link. We know that these characteristics are modifiable and that we can modify them through treatment. One of the challenges, though, is how do you do that? A lot of the clinical practice guidelines that we've seen, and this is a nice study from earlier this year that look across a variety of different clinical practice guidelines, they show pretty consistent recommendations for mental health treatments, like one of them being cognitive behavioral-based treatments. And you can see here the green dots indicate that they are recommended. The ORCE guidelines recommend it with some contingencies, and that is that the patient have a diagnosis of depression. And that was for hip-related osteoarthritis. These are knee-specific recommendations. And really across the board here, there's a fairly consistent recommendation for interventions like cognitive behavioral-based therapy for people for which it's appropriate. And so really the challenge then is, how do you take these interventions, these mental health focused interventions, and incorporate them alongside the treatments that we more traditionally consider to be appropriate for osteoarthritis, like exercise or education or physical activity. And that's one of the biggest challenges, I think, for physical therapists in sort of my area of research, but really anybody that is managing individuals with osteoarthritis. And one of the ways that we are looking at addressing this at Duke is through the use of mental health phenotyping. And I know that many of you are probably familiar with the term generally of phenotyping. I'm not going to read through these here. You can read through those on your own, but these are definitions of phenotype, of what a phenotype is, provided by the NIH Pragmatic Trials Laboratory. And a couple of things that I want to point out here is that they are observable and they are measurable. So inherent in these being measurable is that we have to do a good job of measuring different mental health constructs. So I want to take a moment here just to pause and talk about why it's important to take a comprehensive approach to measurement. On a few slides back, where we talked about all of the different components of mental health, you can see a variety of different characteristics. Now, a lot of those are related, but there are also many of them that are distinct. And the way that you might treat something like depression or anxiety would be different than you would treat catastrophizing or pain-specific anxiety. And so it's really important to tease apart what these different psychological characteristics are and understand how we might treat them more effectively. We've done some work to look at this concept of how much overlap there is with different psychological constructs. And it really tells us a lot about why comprehensive mental health assessment matters. We took 754 individuals that were being treated here at Duke with knee osteoarthritis. They all filled out the CCCR at baseline, and we looked to see how different characteristics, mental health characteristics, were associated with their self-reported function. We controlled, you can see there on the bottom, for characteristics like age, sex, race, BMI, marital status, employment, insurance, comorbidity index, and KL grade. So the degree of degradation within the joint. And we used factor analysis to identify these two distinct factors. So one being a pain coping factor, and that was consisted of things like catastrophizing and kinesiophobia, fear of movement, fear of re-injury. And that was distinct from mood-related characteristics like generalized anxiety, depression, and anger. So these statistically were different factors that we identified within these folks with knee osteoarthritis. And then we looked to see how well or closely, how strongly these were related to those KOOS scores. And what we found was that the pain coping factor was much more strongly related at baseline. And we think that this is important because if we're really only focused on evaluating depression and anxiety, we may be missing some characteristics that are really closely tied to how somebody functions. And that's really important, I think, for treatment, because they're definitely treated a little bit differently. The way that we would measure then, if we're considering the fact that we need to do a comprehensive or take a comprehensive approach to assessment, the way that you would typically do this is you would administer multiple questionnaires. So one to evaluate depression and anxiety and pain catastrophizing, kinesiophobia, the positive characteristics like self-efficacy or pain acceptance. But obviously that can be very onerous for physical therapists, for anybody that's collecting this information. Patients don't like to fill out all these questionnaires. So one of the ways that we've tried to address this is by developing a single questionnaire that evaluates multiple constructs and essentially screens for these different mental health needs or mental health characteristics. And what we developed, and this was actually published back in 2016, is what's called the OSPRO Yellow Flag Assessment Tool. And the questionnaire itself looks like your traditional mental health screening tool or questionnaire. It has 10 items, but the way that it functions is very differently than most questionnaires. In most questionnaires, you would fill all these items out, and then you would add it up and you'd get a single score. This one works a little bit differently. What it does is it's probably best described as a calculator. It would estimate what a patient would score if they were to fill out full-length questionnaires for each of these 10 different questionnaires, psychological questionnaires here that you see on the screen. So rather than having somebody fill out a full-length PHQ-9 or a full-length pain catastrophizing PCS, you could have them fill out this 10-item questionnaire, and it would estimate what they would score with pretty high accuracy. We've developed a scoring website. You can go to this QR code here if you're interested in learning more about this scoring or the tool itself. And what this does is it allows you to put in the items over on the left-hand side, and then it gives you the score estimate there in that table. And it also identifies what we consider to be a yellow flag. And the yellow flags are basically just those score estimates that fall into the top quartile or the worst quartile of the population of people with musculoskeletal pain. So on this next page, or next slide rather, I've kind of broken that down just a little bit more, and we can talk through how this works. So say, for instance, somebody fills out the OSPRO Yellow Flag tool, they would have an output that looks something like this. So for instance, if they were to fill out a full-length pain catastrophizing scale, the PCS, the OSPRO estimates they would score about a 24 on that scale. And a 24 puts them in, it's a pretty high score for the PCS, so that puts them in the top quartile. And what it does now is it triggers a yellow flag. So it indicates to the person that is administering this tool that, well, this person may have some issues or things that we may want to consider related to how they catastrophize about pain or how they think about pain. Those are things we may want to consider as we're going through their rehabilitation. So what we've done then in using this tool to move forward with developing phenotypes is we've taken these the yellow flag indicators, so basically the yes or the no, and we've tried to use this information then to identify how these different characteristics tend to group together in patients that we're seeing for osteoarthritis. And really the benefit, I think, of phenotyping is, we want to deliver care that is personalized to the patient. And that may include things like physical activity training and exercise, and also mental health interventions. But to do that at scale tends to be somewhat challenging. So one of the things that we tried to address in our management of people with osteoarthritis is how can we more effectively, more efficiently deliver mental health treatments? And by taking a phenotyping approach to that, that's how we felt like we might be able to take a step forward in this area. So the way that we developed these phenotypes, we used data from about 1,200 patients that we saw in our joint health program with hip or knee osteoarthritis. And we used a technique called latent class analysis. And it's really a statistical technique that is a clustering or a grouping approach that identifies characteristics that tend to cluster together. And latent class analysis is useful for when you have dichotomous indicators, so a yes or a no. So we use latent class analysis in this case because we're looking at whether or not they have a yellow flag for these 10 different characteristics. And what we found was that the largest group, the largest phenotype, if you will, is one that was defined by high levels of distress. So basically what this was about half of the total sample. were defined by high probability of having a yellow flag across almost all of these different psychological characteristics, or at least the vast majority of them. On the other end of the spectrum, we saw that there was about a quarter that had the opposite, so the low distress characteristics. So really low probability of having a yellow flag on any of these things that we're measuring. In the middle, we found the final 25% or quarter or so were defined by either low self-efficacy and acceptance. So this is low pain self-efficacy, low chronic pain acceptance if they have chronic pain because of their osteoarthritis. And then a smaller group that was primarily classified by poor pain coping strategies, or skills rather. So things like high levels of catastrophizing, high levels of kinesiophobia. So I think there are a couple of things that are really important here to not only look at what the composition of these groups are, but also the relative distribution of these also. I want to talk just a little bit about, kind of drill down a bit into those different phenotypes to show you how they presented on with some other characteristics. So we really didn't see major differences between these groups when you look at BMI, age, or gender by joint. But where we did see differences, and you probably expect this, is in their pain intensity, and also their self-reported function. I'll start with self-reported function on the Hoos of the Coos, and you can see that in the high distress group, those Hoos and Coos scores were relatively low, indicating high levels of disability. It would make sense then that in the low distress group, we didn't see those really significant levels of disability, or at least not as bad as we did in the high distress group. The low self-efficacy and the negative pain coping groups were somewhere in between. And we saw a similar sort of profile when it came to pain intensity as well. So much higher pain intensity when you look at the high distress group compared to the low distress group. One of the other things that we wanted to evaluate was whether these mental health phenotypes were specific to osteoarthritis, or whether we would see them when we looked at other different pain conditions or musculoskeletal conditions. And so we, over on the left-hand side there, you can see the hip and knee OA cohort that I just talked about, but we also looked at this in patients that are coming into our sports medicine clinic. And then also in a separate analysis that I looked at with a colleague, Dan Ron, in the military for people with low back pain. What we found, generally speaking, was that there was a high distress and a low distress group. In those two other cohorts, we did find a group that was defined by low self-efficacy and poor coping as well. So a lot of consistency in high distress, low distress. As you get into some of those smaller subgroups, it becomes a little bit less consistent on what you're seeing from cohort to cohort. But one of the things I'll point out here too is that those high distress groups were much smaller in the sports medicine and the low back pain in the military group. I think one of the things I'll point out before I leave this slide is just going back to this issue of evaluating depression and anxiety only in healthcare settings. So if we were only to look at depression and anxiety, we wouldn't be able to identify these groups that are either in the yellow or the orange or the gray. And those are individuals that could very well benefit from interventions that we can provide as rehabilitation specialists to reduce catastrophizing, to improve pain coping. And yet, if we're not evaluating those characteristics, we're missing a fairly sizable number that we can have a meaningful, I think we can have a meaningful impact on in terms of their level of disability and pain. One of the other, I think, predisposing or underlying needs, rather, in taking this approach to phenotyping and treating based on phenotypes is to make sure that when we're looking to assign phenotypes or identify which phenotype patients are likely to fall into, that healthcare providers agree on what the phenotype assignment is. Because if you have a patient that goes to 3 different healthcare providers and they disagree on what phenotype, then it really doesn't help very much to develop pathways or clinical pathways that are specific to those phenotypes, because they're not going to get consistent care. So we looked at this issue of agreement on different phenotypes, and we had basically developed some vignettes where we showed these the OSPRO Yellow Flag Assessment Tool scores, and then asked these people who were participating in this survey research to then assign them to one of these phenotypes. And we did quite a bit of education on the people that were completing this survey on what the different phenotypes are, how they're defined, and made sure that they really understood what these are before actually going in and assigning them. We had 22 physical therapists and then 23 physicians or surgeons that completed this. And we looked at the Fleiss Kappa, which is basically a level of agreement. These are some forest plots of kappa, and you can see how this is broken down. Up on the very top, this is basically their agreement across all phenotypes, where we found a moderate level of agreement. These are the point estimate and the 95% confidence interval. What's interesting here, maybe not too surprising, is that as we break down the actual phenotypes and look at agreement, it was relatively easy to identify low distress and high distress. But when you get into the more nuanced phenotypes, like those that have low self-efficacy or those that have poor pain coping, that's when it became a little bit more difficult to agree on which of the phenotypes they fall into. We also looked at sort of an interesting approach here, where we just gave them information on the OSPRO score. And then we also gave them more information on a couple of the vignettes, where they would also have PRO information on their KOOS. We would have information, demographic information, pain-related information, KL grade. And by giving them additional information about the patient, it actually helped to improve their agreement, which is somewhat interesting because in the latent class analysis that we used, we didn't include all that demographic information in there. So it seems to suggest that there is some value to having this other information and helping them to assign which of these phenotypes the patients fall into. We also had some of these interviewees that, or survey respondents rather, that were somewhat familiar with phenotyping, and those that had some familiarity with phenotyping did a little bit better in terms of their agreement. We really didn't see a major difference between physicians and physical therapists, or people that were early or later in their career. So what this suggests is that by giving healthcare providers more information about the patient and educating them on phenotyping, that we could potentially optimize the level of agreement that people have. What we're trying to work on now is to actually try to bypass this issue altogether and incorporate the phenotyping assignment directly into Epic. It sounds really simple, but it's surprisingly difficult, as I'm sure many of you may be familiar with if you've worked with trying to get these types of decision aids built into Epic. So that's really our ultimate goal, is to be able to use this information and incorporate it into a decision aid that automatically pops up, but that's not something that is going to be available to most people. So I want to get back to talking a little bit about now how we are incorporating this information and this approach to phenotyping into clinical practice, because I think this is a really important component. And I want to talk about some specific examples of how we are doing that within the Duke Joint Health Program. I think lots of times when we consider addressing mental health, I think our minds immediately go to this type of scenario where you have somebody that's in mental health counseling, meeting with a psychologist or behavioral health specialist or psychiatrist. And what's really important to recognize is that there are probably more opportunities now and resources now to address mental health than there ever have been before. And they don't all look like this. There are a lot of different options that can be provided by non-psychologists, non-psychiatrists, non-behavioral health specialists. Physical therapists are becoming more involved in delivering care that is mental health focused. Nurses, health coaches can deliver this level of care. We're also seeing different modes of treatment as well. So it's not just the face-to-face sitting in in an office with a psychologist. Now we're starting to see more options popping up in mobile apps, online, different types of treatments, CBT type treatments, mindfulness-based treatments via mobile app. And so there are a lot of different opportunities that we have now to address some of these needs, particularly those that are pain specific. And I think for a lot of these different mental health characteristics, it may not even be an indication for mental health counseling. So we want to kind of move away from that idea that because somebody flags for a mental health need, quote unquote, that they have to go into mental health counseling, and that's simply not the case. So I'll talk a little bit about some of the things that we're doing in the joint health program, but these are some of the options that can be provided by non-psychologists. So progressive muscle relaxation, graded exposure and activities, which may be something that's particularly important for people that have high levels of fear or catastrophize about certain activities that they think, well, I can't do this because I have, bone on bone, joint pain, and it's going to be damaging to my knee or to my hip. And so by exposing them to activities and helping them to understand that this is something that you can do and that you can do safely, that's a mental health focused intervention that we as physical therapists or rehabilitation specialists can provide. There's guided imagery, motivational interviewing, particularly when you're setting goals. Activity recycling, I think, is something that's particularly important for people with osteoarthritis, any chronic pain condition, to help them to understand that it's that the rest component is just as important as the activity component. Principles of reward and reinforcement, building those into different physical activity programs or exercise programs. Pain education, pain neuroscience education is one of those out there now, where there's some support in the osteoarthritis literature. I think the jury is still out on how much of an impact that has, but certainly that's one of those interventions that's being used in chronic pain conditions quite a bit now. And then also mindfulness, so mindfulness-based stress reduction and a variety of different mindfulness techniques that help to reduce stress, help to reduce anxiety, help to reduce catastrophizing for people that are experiencing pain. And all of these types of things can be integrated into treatment. I've mentioned this a couple of times. We have the Duke Joint Health Program, which is somewhat unique in that it incorporates physical therapy. Orthopedic surgeons are part of this program and help to develop it. It also has psychologists, dietitians, pain management specialists that are all coming together to help build a comprehensive approach to osteoarthritis management. And what's somewhat unique about this program, we've seen this a lot in managing low back pain, where you have a primary spine practitioner, so a condition-specific specialist. Here we have an osteoarthritis specific specialist called the primary osteoarthritis provider, which at Duke, these are all physical therapists, and what they do is act as a quarterback, if you will, for helping to oversee the care of individuals with osteoarthritis. And you can see a couple of the different treatments or approaches, resources that are provided as part of this program. Some of these things is care that the physical therapists themselves are delivering. So like, for instance, these cognitive behavior-based, theory-based strategies, our physical therapists are trained in delivering those strategies so they can deliver that. If it's someone that needs a little bit more care, particularly mental health care, then they can refer out to a psychologist. If somebody needs help with weight loss or nutrition, they can refer out to a dietitian. So this is really designed as a comprehensive approach to management. We have incorporated OSPRO into Epic, and this is something that can be pushed out to patients. So the POPs that are working in the joint health program, they have access to this information, and they can use that then to identify which of the phenotypes patients are likely to fall into based on their OSPRO scores. And what we've designed, and I say we, I'll actually give all the credit to the physical therapists that I'm working with in the joint health program, have designed a couple of different pathways, treatment pathways that are mental health focused, that are aligned with these different phenotypes. So the first would be for those that might be more consistent with the low distress profile. This might look like your traditional physical therapy approach. So impairment-based intervention, self-management, these could be your one and done, if you want to call it that, patients where they come in for an evaluation, they get some education, exercise, home exercise program, and then follow up as needed. For those that have needs related to low self-efficacy, they integrate value-based goal setting and some accountability check-ins. If there is some needs related to poor pain coping, then they would add in graded exposure type activities, which I talked about just a minute ago, maybe some pain neuroscience education to try to help to reduce some of the catastrophizing, help people to understand that they can do these activities despite the fact that they have pain. And then for the higher distress group, this is when we would typically see consideration for more multidisciplinary intervention. So not only treating them in the way that we would typically do as physical therapists to address some of the physical impairments, but then also getting behavioral health involved or psychologists involved, and really, I think, relying more on these psychologically informed techniques, and probably a little bit more closely following up these patients to make sure that they are progressing the way that they should. One of the areas that I think is really important to talk about when we discuss this issue of phenotyping and really mental health more generally is how do we effectively communicate with patients about mental health? Because I know that when people come in to see me as a physical therapist, they're not typically expecting to talk about their mental health. They expect that I'll talk with them about their knee pain, about exercise, about their function, are able to go up and down stairs. But they're probably not likely to expect that I'm going to talk to them about how this is affecting them from emotionally or from a mental health perspective. And so it becomes just as important to make sure that we can effectively communicate about mental health as it is to actually deliver some of these treatments, because we want to make sure that patients are open to that. And more recently, I've started working with a group out of the University of Texas at Austin. They have a think tank there that's focused in their, I believe it's their communication department, where their focus is on how to effectively communicate different healthcare terminology and issues with patients. And so I've consulted with them about how to do that related to mental health. And I want to go through just a couple of different ideas about how we've come up with to talk with patients about this. If we consider that there are a couple of different steps in this process, not only administering some of these screening tools, but then also talking with them about the results, I want to talk about how we might communicate with patients at each part of those steps. So if we're talking about the initial screening, again, patients may expect that they're going to have questions about their knee pain, but not so much about mental health. So if we are expecting them to answer some of these questions honestly and to be forthright about how they're feeling, what we can say to them is, sometimes pain causes certain thoughts and feelings and actions, and we want to know more about these things so that we can understand the experience that you're going through. We can also say something like, the more we know about how it affects you, how it affects your life, the more effectively we can design your treatment plan, which may include additional services beyond what the physical therapist is able to provide. The other thing that's important is that we don't create stigma around this. So we don't want them to think that, well, I'm asking you these questions because I think there's something wrong with you. You say, we ask everyone these questions so that we can establish the right treatment from our team, our entire team, at the right time to make sure that we can address your needs. And then when it comes to treatment, if there is some need to discuss treatment for these patients, say, for instance, they screen high on some of these questionnaires, or they have a phenotype which is somewhat concerning, it's really important to try to approach them to open up that discussion and make sure that they have some agency in making that determination about whether that's something that they want to discuss. We care about you as a whole person and your health in general. We have people on our team who can help with this. Would you like to talk through some of these possibilities and some of these options that we have? If you're willing, let's set aside some time, a few minutes throughout our evaluation, because I want to talk with you about how your knee pain or your hip pain is affecting you more generally. If there is the need for referral, then some of the things that we can say to them is that pain affects so many areas of your life. It helps to have the best team of providers. And we do have a great team of providers that can really help you, that extends well beyond just me as your physical therapist. What are your thoughts about seeing some of these providers that specialize in mental or behavioral wellness, in addition to participating in physical therapy? One of the interesting things that they've mentioned is that rather than saying that you're going to psychotherapy or psychological interventions, you can say something like, let's talk about some coaching to help you better manage your pain. So coaching isn't necessarily as off-putting as psychological intervention, which I know for many, may cause them to shut down. Some different ways that we can talk about targeting treatment. You have some concern about movement and physical activities, or ways that we can work together to test how these different movements feel. So for instance, somebody with catastrophizing, as we find ways to increase your motion activity, we can improve the odds that you're going to get back to doing the things that you really enjoy. If somebody's having some issues with pain coping, I can see this has been challenging to cope with pain and all the other things that are going on right now in your life. And it makes it hard to engage in the activities that are meaningful to you, or engage in the activities that we're going to be doing here in rehabilitation. We can find strategies that help you to improve the way that you cope with pain so that you can meet your goals. So I think these are different ways that are, really important to try to get patients on board with understanding why this information is so important to gather from you, but also why it's important to be forthcoming in how you're feeling, and how we can use this as healthcare providers to provide better outcomes. Because I think what we have found in talking with patients is that they are willing to provide this information to you, but they need to understand why it's being asked and how it's going to be used. So making sure that we're effectively communicating really is quite important. I did want to leave some time for some discussion here, but I want to summarize with just finish up here with a couple of things that I'd like you to take home as take-home messages here. As I pointed out initially, mental health does have an important role in how people experience osteoarthritis. I think we're starting to understand that not only as a prognostic factor, but something that we can intervene in to help improve outcomes for people with osteoarthritis and after surgery for joint replacement. We do have efficient and comprehensive mental health screening tools. The OstePro is really designed to be one of those. There are a number of other tools that are out there to do that. Distinct mental health phenotypes are present in people with osteoarthritis. And, I think it's really important to point out here a couple of limitations of this work. Number one, these are designed these are identified rather using statistical techniques. So statistically, we can identify different clusters of mental health profiles. But there are some things to consider. These don't seem to be specific to osteoarthritis necessarily. There are a difference in the prevalence of these different these different profiles, these different phenotypes in people with osteoarthritis or different conditions, but they don't seem to be specific to osteoarthritis. The work that I've shown today and the work that I've done to date has largely been cross-sectional. We are doing some work to look at how well these can predict being assigned to one of these phenotypes or falling into one of these phenotypes rather. Can predict outcomes, but right now we really don't know how well those can be used for prognosis. And we also don't know whether taking the extra effort to identify a phenotype is better than just simply using, let's say, their score on a pain catastrophizing scale and a PHQ-9. So we're trying to understand how we can optimize the measurement of this to make sure that it provides information that's useful in practice without being overly onerous. And then really what we don't know yet, and also something that we're looking at within the joint health program is if we have these treatment pathways and we take this approach of phenotyping with the goal of developing treatment that is specific to those phenotypes, does that result in better outcomes? And the truth is I don't know. I think that's something that we're really interested to find out. We're starting to do some initial work in that area right now. We know that in low back pain, when you look at stratified care programs for low back pain, the results haven't been promising. There are a lot of issues with those related to implementation as opposed to the effect or the efficacy of stratified care. So that's certainly something that we want to look into. And also, I think it's important to point out that this is not necessarily designed or intended to be, I don't want you to conflate this way of managing mental health needs with the best way to manage osteoarthritis. I think what I'm trying to show today is if there is the intent to try to better manage mental health for people with osteoarthritis, this is simply one way that we might consider doing it. And then finally, the last take-home message here is that there are a lot of different intervention opportunities outside of your traditional psychological or mental health counseling platform or way that that's done traditionally, that I think can really help to address a lot of the needs of patients with osteoarthritis, assuming that we are evaluating and measuring the right things. I do want to finish up by acknowledging some of my colleagues here at Duke, physical therapists, psychologists, and surgeons who have been really instrumental in developing the joint health program and a lot of the work that's come out of the joint health program, a lot of which I showed you today. So this has been a really great group to work with, and certainly a lot more work in this area as we move forward. So with that, I'll leave just a little bit of time here, hopefully, for some Q&A, and happy to take any questions or feedback that you have.
Thank you, Trevor. Just a reminder, if anyone wants to ask a question, you're very welcome to either put it in the chat or unmute and ask Trevor.
I'll jump in. Thank you, Trevor. That was very interesting, and a lot of interesting things going on with your joint health program as well as all of this. My question, one of my questions is, what is the role of socioeconomic status and social determinants? What's the profile of your patient population, and does that make a difference in some of the groups?
Yeah, that's a good question. I think we had limited information on the socioeconomic profile of that patient population. We're actually doing some work now to try to understand a little bit better about who accesses the joint health program and whether we do get a representative sample of people with osteoarthritis. I think some of the initial findings is that we do a pretty good job of enrolling people in that program who are more affluent, who are white, who have commercial insurance. So we know that there are areas that are underrepresented in some of the data that we have, or at least some of the population with osteoarthritis. I think, to get back to your question about the socioeconomic or social needs, rather, I think there's a really, I believe, really interesting interplay between, mental health characteristics and social needs, and that I think we can identify people that have significant mental health needs, but if they have really great social support, maybe it's not quite as important, or the need isn't quite as much there for us to try to intervene for those patients. Whereas if you have somebody with the same mental health needs, but that don't have any of that support, then we may need to take an extra step to see what types of resources we can help to provide. Those patients are probably at a much higher risk for poor outcomes, or even the inability to participate fully in the programs that we have. So that's an area that, admittedly, we've tried to. This is a huge issue. We've tried to take a small bite out of this by looking at mental health, but the social component is an area that we're starting now to try to consider and figure out what role that has, or at least how we can incorporate that information into the phenotyping to try to provide better care, more personalized care for these patients.
Thanks. No, you're taking it's a huge bite, and you're starting very judiciously.
Yeah, thanks for the question.
Hi, Trevor. I love the talk. Thank you so much for giving it. I am a researcher at the CVM at NC State, and our research group is actually starting to look at pain catastrophizing and if we can quantify it in dogs and their owners, if their owners catastrophize about their dog's pain, similar to children and their parents. Mm-hmm. I was just really fascinated by your approach with the OSPRO, and I was wondering which item you found loaded well onto, or like which one you could use to take that score for the pain catastrophizing scale?
Yeah, that's a good question. So I'll I have to explain sort of how the OSPRO works. It's kind of an interesting tool in that there's not one particular item that is used to identify a level of catastrophizing. What it actually does is it takes all of the different items, all of the 10 items, and there are different loadings. I have to go back and look at the specific loadings. So I can get you that information. I don't know it off the top of my head right now, but I can definitely get you that. But the way that it's designed is that you have to have all of the items answered, because it uses these equations with basically different weights that are multiplied by the responses to give you the overall score. So you can't just pull out one item and say, well, this is used to identify their level of pain catastrophizing, if that makes sense. I will say, outside of the OSPRO, there are some other, and you're probably familiar with them, some short forms of like the pain catastrophizing scale that you might consider using if you're looking at catastrophizing specifically, which I can send you offline. But yeah, unfortunately, the way that it works, and this is also a challenge clinically, is that there has to be complete data. They have to complete all 10 of those items to get really good, accurate scores for what somebody would score on the pain catastrophizing scale. But the benefit, I guess, would be that you could also look at self-efficacy in dogs or their owners with the OSPRO, because you're measuring all of those other different characteristics.
Yeah, absolutely. It was really cool to see all that. And I had one other question. The high distress group, what markers made them a high distress? I know you said the poor pain coping was also characterized by pain catastrophizing, and some other things. Was pain catastrophizing something that characterized in the high distress group too?
Yeah, that's a good follow-up question, because I didn't spend a lot of time on that. But with the high distress group, and let me see if I can go back really quickly. But the high distress group was basically defined by high flags or a high probability of flags in all of those different categories. So we talked a lot about, let's see here if I can get you to this one. So we talked about, how, like you mentioned, the poor pain coping group was really defined by like catastrophizing and high levels of kinesiophobia. The high distress group had a high probability of having a flag on the vast majority of these. So where we would see that is not only in depression and anxiety or anger, but also in catastrophizing, also in low self-efficacy. So it was really a profile where they had, issues across the board. What defined that high distress group compared to the others, which is something that I think is important to recognize, is that those other groups didn't have the issues related to depression and anxiety or anger, the mood, quote unquote, mood conditions. What really tended to define the high distress group was that they did have a flag in those mood conditions, depression, anxiety, or anger, or multiple ones. So it was really across the board on those. Does that answer your question? Does that help? Yeah, go ahead.
Hey, Trevor, that's
Hey.
great talk.
Thank you.
I'm curious, we try to avoid medications and antidepressants, and they're overused, but do you think, and maybe you're going to look at that, is there a phenotype where those particular people with OA would be more likely to respond to a low-dose antidepressant, that we could, use more targeted therapy for them? Which is approved for OA treatment, but is, I think, somewhat controversial in terms of using it because of side effects.
Yeah, that's a good question. I guess the honest answer is I'm not sure. I would imagine, I think that would be great to look at, to see, like I mentioned in the last question, the only one that really had major issues related to depression or anxiety or some of the mood would be that high distress group. So that might be kind of the low hanging fruit there in terms of which ones we might consider initially, because those are the ones that are probably going to benefit the most, at least in my mind, from you know, a more multimodal, multidisciplinary approach. So perhaps those would be the ones. One of the interesting things that we've found, and this is all anecdote, I don't have, you know, data to support this necessarily, but in talking with some of our joint health program physical therapists, they think that the low self-efficacy group, you know, these are the ones that are probably the most likely to transition pretty quickly with just a couple of visits into like the low distress group. So we think that those are the ones that, you know, we probably don't need to do a whole lot beyond our more traditional care, or maybe incorporating some you know, lower intensity CBT type interventions. But I would think that you know, to your question, it would either probably be the high distress or the pain coping group. But I think it's a really great question, and that's really where our initial step was to identify these, you know, get some information on who they are, how prevalent they are, how they present clinically, and then now it's great because there are so many questions like that we're trying to answer about how do you best manage these patients. Do we need to make a distinction between those two smaller groups in the middle, or, you know, can we treat them the same way? You know, so that's really where we are. But yeah, it's a great question. Yeah, go ahead. No, someone has their hand up. Yeah, go ahead.
I have a question, just like, do you have any plans on collecting some blood biomarkers to identify like pain biomarkers on molecular level? So you will understand why some people with the same, you know, disease state have like more pain, more catastrophizing. So just to explain this on a biological level. So, and maybe this, you know, pain phenotypes, they could be identified early to address this before they start like depression.
Right. Yeah. And that, admittedly, that's an area that I have done no work in the blood biomarkers. I know that there's some, you know, some of my colleagues here at Duke are doing work in that area. Adam Good, Steve George, looking at, you know, biomarkers and blood biomarkers and how they can be used to identify some of these patients. And in particular, you know, how you can use, I know that, you know, question earlier about using some of the antidepressants and pharmacologic management alongside these interventions that are more mental health focused to improve care. So no, to directly answer your question, we haven't looked at this. I think it would be a really great thing to look at, to figure out whether we can identify these earlier, or whether there are different biomarkers based on these clinical presentations, because again, these are all things that we observe just based on their questionnaires that they're filling out, but really nothing beyond that. So I think that's a great point.
Yeah, just like to identify like pain phenotypes, like from blood, and associate them back to behavioral phenotypes. It's like,
yeah, I think it's a great area. Like I said, we haven't done any work in that specifically. I think what we're considering, you know, next is where we take some of this work, and that might be one of the areas we also want to look at trials where we are comparing this sort of stratified approach to something that's less or not stratified, you know, more the traditional care, to see whether this matters. And so that might be one way that we can look at identifying these people much earlier in the pathway.
thank you.
All right, we're at 11:30. Trevor, I have like 8 questions for you, but I'll handle them offline.
I know where to find you.
I appreciated that. I know many others did too. And yes, if others have questions that you weren't able to answer, you can get them to us and we'll get them to Trevor. And thanks again, everybody.